I'd like to officially commence the webinar. Thank you very much, everyone, for joining us. And I'd like to welcome you to the second in our series of COVID and detention webinars, this one on the theme of decarceration. Before going any further, as is traditional in Australia, we want to commence this by acknowledging the traditional owners of the land that we're on and the traditional owners of the land that you may be on. For me, I'm the land of the Wurundjeri people of the Kulin Nation, and it's appropriate for us to pay respect to their elders past, present and emerging. Today's webinar is co-facilitated by myself and Claire King from the Justice Health Unit, and you'll hear a bit more from Claire later. Before I start, I just want to very quickly acknowledge the funding support we have for this. It's co-funded, this series of webinars, by ourselves and by the Centre for Health Equity at the University of Melbourne. And I also want to acknowledge the many people in the Justice Health Unit who've been helping us coordinate this series of webinars, and also T. Hin and Lily May for providing tech support from the university. It's a real thrill to introduce our four panellists for today. We're really, really grateful for their time and excited to hear what they have to say. Our four speakers are in the following order. The first is Professor Lorana Bartels, who's the Criminology Program Leader at the Australian National University and an Adjunct Professor of Law at the University of Canberra. And Lorana has very kindly joined us despite suffering from a migraine at the moment. So I have enormous respect for you soldiering on, Lorana. And for that reason, Lorana may leave us after giving her presentation and answering a few questions. So if Lorana does leave, she means no offence. She's just remarkably soldiering on at the moment. Thank you. Our second speaker is Associate Professor Lisa Puglisi, who's an Assistant Professor of Medicine at Yale University, talking from a US perspective. And our third speaker is Rashad Mumuni, and I'm sorry, Rashad, I'm not sure how well I've pronounced your name. Hopefully you can improve it for me when it's time. Rashad is a registered mental health nurse and member of the COVID-19 team at the Kumasi Central Prison Medical Unit in the Ghana Prison Service, and I'm really looking forward to hearing what Rashad has to say as well. And our fourth speaker is Dr. Paul Simpson, who's a research fellow in the Justice Health Research Program and part of the Australian Centre for Research Excellence and Offender Health at the University of New South Wales. So our format today is to have four brief presentations. In this case, Lorana will take a few questions immediately after her presentation, and those will be facilitated by Claire. Then we'll go on with the other three presentations without really pausing for anything but essential questions. The idea being to give plenty of time at the end for a conversation. So throughout this webinar, I'd invite everybody who's participating and listening in to type in their questions, their comments into the Q&A. Claire will be busily collating those and trying to convey the key themes to our panellists for the question and answer session. So please, if you do have anything you want to say or any questions you want to ask, type those into the Q&A panel at any point during the webinar. This is, as I've explained, the second in a series of 6 webinars on the theme of COVID-19 and detention. And the series is about understanding policy and operational responses to COVID-19 in places of detention so far, identifying some of the things that in the view of our expert panellists have been missing. And at the end of this webinar, developing some recommendations for what we hope will be comprehensive, sustainable and cross-governmental responses to COVID-19 in places of detention. There are 6 webinars. For those of you who missed the first one, you can find a recording on the Justice Health Unit website, and you're very, very welcome to register to join any of the other webinars coming up for the rest of this year. So enough from me, and with no further ado, I'll hand over to our first speaker for tonight, Professor Lorana Bartels. Lorana, over to you.
Thank you, Stuart. And I would like to acknowledge the traditional custodians of the land here where I'm coming from in Canberra. That's the Ngunnawal people. And in particular, pay my respects to their elders past, present and emerging, but also acknowledge that where I'm coming from today in Canberra has just today become the first place in Australia to legislate to raise the age of criminal responsibility from 10 to 14, and that's a really long overdue achievement, but especially in the context of decarceration, I think an important one to acknowledge. And one of the other things I did today was I was out at our youth detention centre where I sit on the school board and had a chat to a few of the young people out there. And we're very lucky here in Canberra. We don't have any COVID at the moment, remarkably, but you know, it's still a very stressful time for people inside, obviously. So we've all been asked as the panellists to speak to three particular themes. Firstly, how important has decarceration been as a response to COVID? And just to set the scene in Australia, for those of you who are overseas, I need to explain that we have a federal system here. We have 8 states and territories and 8 prison systems as a result. So the responses have been very fragmented. There hasn't been a universal national response. Regrettably, decarceration has not featured heavily in the response of any of those 8 jurisdictions. And my involvement with this kicked off in March when I led co-wrote first an open letter in March calling for the early release of some people from prison, but also greater use of bail and community-based sentencing options. And that was signed by, I think, about 380 academics, lawyers, medical practitioners across the country. And we disseminated that to the media and politicians across the country. And New South Wales, which is the most populous state, about 4 or 5 days later did legislate. They passed the first COVID emergency legislation in relation to prisoners, granting powers to release a certain cohort early. And we're elated. We thought that we'd achieved a real policy win, but regrettably they passed legislation and still have not in fact released anyone early. And the commissioner there said, you know, he was pleased he had these powers, but didn't see that, you know, hoped he wouldn't have to use them. So it was very much pitched as a reactive rather than a proactive stance. And that's really characterised the approach in Australia to date. This sort of, we'll get there if we need to get there, rather than acting in a way that would be preemptive, proactive, and move towards reducing the number in prisons. Well, a few months down the track, and then there was a second open letter and a third open letter. But interestingly, a few months down the track, our prison numbers are down, and they're down significantly. And this has especially come in the context of remand, so unsentenced prison population. So in New South Wales, the number of people in prison dropped by 11% between March and May. And in Victoria, which is experiencing our largest COVID issue at the moment, the numbers dropped by 13% between February and May, and impressively, even more impressively, the number of women dropped by 23%. And that really, I guess, gives us hope that we can see decarceration happen in our lifetimes, but it wasn't as a result of any proactive stance by the executive or legislators. It's been principally fewer charges being laid and bail being granted, and some people being released early or getting non-custodial sentences, but it appears to have been more in the remand space. And that's also reflective of the trends in imprisonment in Australia in recent years. So over the last 5 years, our remand imprisonment rate has gone up by nearly 50%. So that's really where those changes should be happening, and happening fast. But it's been really this sort of frustrating sense, I think, that there hasn't been a willingness to engage with the issue. And in particular, for those who are listening from overseas, the overrepresentation of Aboriginal and Torres Strait Islander peoples, the Indigenous peoples of Australia, is at extraordinary and shameful levels. They're 15 to 20 times more likely to be incarcerated. They make up only 2 or 3% of the Australian population, and about 28% of our prison population, over a third of our population of adult women in prison, and over half of our young people in detention. So recognising the urgency of decarceration in relation to the Indigenous population, especially because they are also more likely to suffer from chronic conditions, which makes them both more vulnerable to COVID, but also more vulnerable to serious implications from COVID. So we've really struggled, I think, to get traction in this space. Australia's been quite lucky in that we haven't had vast numbers of people in prison getting COVID, but there was a staff member announced just today. They've been in Victoria, I think at last count, correct me if I'm wrong, Stuart, 11 young people in detention who went in testing negative and shortly thereafter tested positive. And the Premier of Victoria has said, I think pretty categorically, that they won't be releasing anyone early. So we're not getting the message through, those of us who are academics and certainly advocates, family members of people in prison, trying to get that message through that what was thoroughly unsustainable before COVID is even more palpably so now. And I think that's the challenge for the coming years to, in the short term, obviously, get politicians and the media willing to engage and do everything obviously possible in a prison setting to maintain distance and sanitation and all of that. But in the medium term, to really shift the discourse on the use of imprisonment in this country. And we've seen 30 years now of very tough political rhetoric when it comes to tough on crime around election times in particular. But many of the states in Australia have one print-based medium, and that's a newspaper owned by Rupert Murdoch, which, if you know anything about the kinds of policies you'd likely see promulgated, it's not a decarceration theme. And Australia has a higher imprisonment rate than all Western European countries, and Canada. We're not in the league of the US, fortunately, but we're not that far behind. So shifting that discourse is the priority, getting people to understand that the vast majority of people who are in prison ought not be there, should be in the community, and the need for all the usual supports that I think people would who work in this space would agree on. Obviously, housing is absolutely critical. Also, mental health, physical health, substance abuse support, education and employment, adequate transport in the community. So really moving that rhetoric from a prison-oriented one to a decarceration rhetoric. And I think another aspect of Australia that is unusual is that our prisons are very expensive. And so I think as our economy, like all other economies in the world, probably struggle, that sort of economic argument, which I make with reservation, but I think it might become more palatable to supplement the humanitarian arguments with the arguments around how costly this is and how it's economically simply not sustainable. I think am I out of my 5 minutes? I could go on, of course.
Thank you very much, Lorana. You've made some really important points there that I'll invite anyone who's listening in to comment on now, and certainly we'll take those issues forward for the rest of this webinar as well. So I might hand over to Claire Keane. If there have been any comments or questions to date, she might be able to convey those to you or to other panellists.
Thanks so much for that, Lorana. It was a great overview to the situation in Australia. I think for me, one of the questions that comes up in this space is we have a lot of issues too with sort of continuity of care for people once they're released from prison. And so how would we decarcerate in a way where people are still supported? Because currently that time after release from prison is such a high risk time already. So how can we do this in a way, if we're increasing that, how can we make sure we do it in a way that is sustainable and that isn't damaging in other ways?
Yeah, and in some respects, I'm probably not the best person to answer it, because I think I'm the only person on the panel who's not a health practitioner. I'm a lawyer and criminologist. So yeah, I recognise that in having that decarceration discussion, it's not like you magically click your fingers and everyone's released tomorrow, that's going to actually be an optimal outcome for them or the broader community, and making sure that they're supported. I understand a lot of the the programs that would normally take place in a prison setting have been suspended, and a lot of that pre-release preparation has also not gone as it ordinarily would. So it's not as simple. And I've had this discussion with, I've had this discussion with our corrections commissioner here, with politicians, and I think it's about starting to have that conversation and recognising, in fact, the inadequacy in the continuity of care going on already, and of course not compounding that. So yeah, I'm more familiar with the issues around housing in terms of primary healthcare and exactly what's required. I can't comment specifically, but obviously I freely recognise that that's a significant dimension to it. I guess I would say, we need to first start having the conversation and seeing the need for decarceration before one gets down to the practicalities of what that might look like. But yeah, it might be something that Paul can speak to in the Australian context with more knowledge.
Definitely. Well, maybe I'll bring that up a bit later too. Okay, so a bit on the more policy side or legislation side, I guess. So what we've been seeing recently is a response to COVID that is quite punitive in nature. So just on Tuesday, a person was sentenced for 2 months in jail for breaching health restrictions in Queensland. I was just wondering, do you think that this is then going to play into sort of a greater focus on incarceration as a means? And how does this play into the decarceration narrative that we have when COVID is encouraging a punitive response?
Well, I think it plays into, or is of a piece with, the general rhetoric in this country, which is a punitive one. And the decarceration narrative, as I say, has not been, in fact, one that has been taken up or let alone led by most politicians in this country. As I say, the ACT has taken a different approach, not just today with its age of responsibility, but we have a justice reinvestment initiative, and the government has actually developed a building communities, not prisons initiative, but the ACT is an outlier in that regard. So the challenge, I guess, Claire, is to critique those punitive responses and highlight, by academics, by legal practitioners, obviously, the inequities that just reinforces, and that I suppose also that that one need not have a big stick approach to it. And it was really interesting in Australia during the first lockdown, as we were seeing reports of fines in well over $1,000 for a teenager who went driving with her mum, and people sitting on a park bench and all of that. Here in the ACT, they did not hand out any fines, and the chief police officer said, we're taking an education first approach. And that was it was consistent with the narrative here, but it was anomalous across the country to be taking that approach. And I don't suggest that we're very lucky that we have no COVID cases, but the police took a very different approach, and then that was very clearly the message that was promoted. That this was about education and public health more than it was about crime and revenue raising.
Thanks so much for that, Lorana. We might keep moving for now, but please keep sending questions, and I'm sure we'll get back to them at the end and pass a lot more questions onto the panel. So if you have more questions, please send them through. I'll just pass back to Stuart.
Thanks, Claire. And thanks again, Lorana, for joining us. We appreciate you soldiering on under the circumstances. And thanks for that fantastic presentation. What we'll do now is move on to our other 3 presenters, and I'll invite them in turn to give about a 5-minute presentation, and we might just move through those without any questions, unless anyone has an absolutely burning question, which you would signal in the Q&A with uppercase, this is an absolutely burning question. Otherwise, Claire, again, will collate those and we'll go through them at the end. And hopefully have plenty of time for conversation at the end. We might revisit some of the issues that Lorana's raised. A real pleasure now to introduce our second speaker from the US, Associate Professor Lisa Puglisi from Yale University. Lisa, over to you, and I'll be the button clicker, so please just say next as you want me to move through your slides.
Thank you, Stuart, and thank you to the Justice Health Unit for the invitation. I'm really excited and honored to be joining this conversation today. So, next, in thinking of what we're talking about here and why the topic of decarceration is even something to be discussing in the first place, I think it's important to start with a common understanding about sort of where this came out of. In the US, which is clearly a very different system than in Australia and in most other places around the world, where 2.1 million people are incarcerated on any given day in over 5,000 different detention facilities. And most of these are not coordinated. They're sort of operating individually or in small groups overseen by a state. The initial recommendations were sort of the kind of general public health recommendations around sanitizing and distancing. And though, large community measures around social distancing in the general community started in the US around early to mid-March, this is a MMWR, a infographic from a Center for Disease Control, MMWR, that came out mid-May, again recommending these sort of basic measures, right? So symptom screening, isolation, distancing, cloth face coverings, etc. But by this point, there had already been large outbreaks starting in some of the jails, large jails such as Rikers and Cook County Jail in Chicago. And people who lived in correctional facilities, worked in correctional facilities, and worked with correctional facilities knew that this was just would not be enough. Some of these things are just quite simply nearly impossible in most of our correctional facilities. Where infection control in large areas with opened with bars and toilets, near beds and all this sort of stuff was just going to be really impossible. And thus came out concepts around the need for decreasing population. Lots of different words: decarceration, population de-densifying. It's fancy words for essentially saying pretty large scale releases that would be needed in order to allow for adequate social distancing. And next slide. And really acknowledging that don't worry about any of the small print on this slide. What you're going to focus on is that we're acknowledging that the rates of infections in prisons in the US is just much higher than rates of infection in the community. On the right side of the screen are the blue bars, which reflect general population community rates in our states. And on the left side, you see rates in the prison populations. And you can just take away the general message that the rates are much higher in our prison populations in the US, state by state. And so those measures were just good and necessary and basic public health steps, and yet really totally inadequate to stop the spread of COVID. And I think a really important concept here is that stop the spread of COVID in correctional facilities, but acknowledging that these facilities exist within communities and that people who work within these facilities exist within communities and are going back and forth to their own families. Often in the US, people who are incarcerated are much more likely to be Black and Latinx and Native Americans, and to, there's disproportionate representation and incarceration of people who are of lower socioeconomic status in this country. But so too are correctional officers from often these very same communities. They too are more likely to be people of color. And so, and they're going back to the same community. So this notion of this divorce where you can talk about, correctional rates and community rates as two totally isolated things is just a fallacy, erroneous, and actually quite dangerous. Next slide. And so we started thinking about the role of decarceration, and as mostly initially it was jails that started depopulating, and that is because in the US, a lot of the jail population, because there's such short stays in jails, has to do with who's coming in. And so when courts entirely shut down, when police stop arresting people and give citations instead, and when money bail is decreased or eliminated, quite quickly there can be a massive drop in numbers of people incarcerated in jails. The prison systems are a whole different ballgame, and that depopulation happened much slowly. But the question really was like, how does it work? What is the impact of this? Like, we're advocating for something which we just ought to advocate for because it makes sense. But in really trying to get more data around it, our group created a model to study what the impact was. So we attempted to estimate the R0 of COVID transmission in a large urban jail early in the outbreak. So really just when CDC recommended baseline measures were being taken, the masking, the sanitizing, stopping visitation. So we kind of call that the baseline. And then this jail took sort of major interventions over time to try to mitigate infection. And so we created this stochastic dynamic transmission model, calculating the R0 early on and then after each of these intervention phases and how it changed over time. This is a classic SEIR model where people come into the jail susceptible, can be exposed and become either infected, symptomatic or asymptomatic, and then will be quarantined, potentially hospitalized, and then go on to recover or die. Next slide, please. And so what we found was, to orient you, I've put a red box around the stuff that actually is important to this conversation. So early in the outbreak, the R0 was 8.25. So that means roughly 8 people would be, the infection would be transmitted to roughly 8 people for every 1 person infected. And then on day 12 started some pretty significant depopulation efforts that dropped the population by over time over 25%. And those were largely efforts around decreasing bail, large community bailouts that the community led, and so on. And with these depopulation efforts, we see that the R0 drops by 56%. To 3.58, and over time there was increased emphasis on single celling. So let's say somebody leaves or gets sick, they would then intentionally not put another person to double up the cell, or sometimes there can be 3 or 4 people in a cell, and efforts were taken to intentionally create single cells, and this then dropped the R0 over time to 1.72, another 51% reduction. And then lastly, they began on after about a month, large-scale asymptomatic testing. So testing, and mostly this was through contact tracing. And you can see that all those measures together and on top of CDC. So it's not that we're actually looking at the impact of any one of these measures alone. It's on top of just general common sense recommended public health efforts. The R0 dropped below 1, which is the goal. Next slide. This was a prettier slide with a nice picture that was too large to transmit, so I apologize for the visual boredom on this slide. But I was asked to talk about overall key challenges and opportunities around decarceration. I think that in the US, there are too many to put on one slide, but we have this huge system. Everyone, most of these individual systems operate independently. There's really very little funding for health services in our prison and jail system. There is this inmate exclusion, it's called, where public funding, Medicaid, Medicare cannot cover medical care inside. And so that leaves for very little funding for healthcare services, discharge planning, and all the important stuff that's needed for people who are more likely to have chronic health conditions and then be released back to the community. Another key challenge is that when you advocate, okay, so that our model showed big impact, right? Depopulation, like really, really impacted transmission rates. You have to have a community health system that's open for business and ready to take people in, be flexible, open their doors, acknowledging the high risk of health issues after release, and creating programs specifically really focused, I think, on the needs of people coming home. And another major challenge is no uniform reporting requirement. So we don't know. We don't know who's being released, how they're being released, how they were chosen, disparate impact on equity, and how these decisions impact fairness around release. But there's a lot of opportunities here, too many to list in one place. But I think that in the US, at least, for once, we find right now, the New York Times just put out yesterday, like 9 of the 10 top cluster outbreaks are in correctional facilities. So it is finally laid bare what probably most people on this call have known for a long time, which is the sheer health risk of that people face being incarcerated, not only around infectious diseases, but this is the one that has brought it to light. And so it is more of a community conversation, I think, than it has been in a very long time. A lot of these efforts to depopulate have brought on more intentional relationships with community and community health systems and health departments. So first time that people saw that they actually needed each other. You need to see what's going on in health and in correctional facilities if you want to manage community health, and vice versa. I think in the US too, there has been a large centering of the voice of incarcerated people, family members, and previously incarcerated people in the discourse, in the newspapers, and that's critical. And then one other one I didn't put on here that I think is really important is in our study, we used staff and incarcerated people as one ecosystem and studied these interventions and how it impacted infection rates in both as a unit. And I think that's critical because we too seldom talk about what's really involved with this massive incarceration system in the US at least, which is a vast number of people who also work in these facilities and then return back to the community. When you think of infectious disease, they too have been disparately impacted. And so I think there's opportunities to create coalitions that have common aims that have been underutilized in the past. And I'll stop there.
Thanks very much, Lisa. That's a really important piece of work that you've presented there, and I'm sure there'll be some comments and questions around that. I'll quickly turn to Claire. Did anybody type "this is a burning question" into our Q&A box, or should we move on to our next presenter? Okay. Thanks again, Lisa. That's fascinating work and some really important points for us to pick up on. With no further ado, then I'll move on to our next presenter, Sergeant Rashad Mumuni from the Ghana Prison Service. And I unfortunately didn't have time to check with Rashad how to pronounce his name. So Rashad, if I've got it wrong, please use this opportunity to correct me.
It's correct, you pronounce this well. All right. Good afternoon from Ghana, and let me take this opportunity to apologize for my inability to connect earlier due to some network challenges. I'm glad to be here, and thank you very much for this opportunity. First of all, in regards to COVID, one way or the other, it's been a blessing in disguise for decarceration in Ghana prisons, because currently we have about 42 prisons facilities in Ghana, with one maximum and one medium, and quite a lot of central prisons, depending on the security features there. But sadly, most of these prison units, one way or the other, were sleep dungeons who have been converted into prison units. So the scope and standard of accommodation issues has been a challenge. And with COVID coming in, especially when you take my facility I work, which is in the Ashanti region, Kumasi. We have about 2,000 inmates in a facility that's supposed to house about 700 inmates. So looking at the overcrowding situation, and when COVID sets in, the Department of Health developed a model with the basic necessities. So we realized one or the other, it wasn't going to work in as much as we were trying to curtail it. So the Director General of Prisons met with the President of the nation and made a proposal of giving amnesty to some inmates. So most age inmates and minor offenders were released, which we have about 1,500 or so inmates were released due to COVID for the decarceration purpose. And sadly, in as much as we were decarcerating people, we were also incarcerating because the crime rates, as in Ghana, is still high due to economic features. So we tried our best to develop isolation units in the prisons, which were temporary holding hubs, but the incarceration was increasing as compared to the decarceration. Because in as much as daily we could let go of, let's say, 50 prisoners, we can handle admission of 100 in a couple of a week. So it became a challenge. So we realized that most of the people and some of the offenses could have been given bail. In Ghana, we don't have what we call the non-custodial sentence. It's not in the Ghana law. It's now being worked on. So we spoke to the Judicial Service, and they rather proposed like reduction in sentences for inmates and some developing a bail system. So we halt the admission of minor offenders and the age into prison custody. Sort of was made into put into fines, and some of them cautioned and signed bombs. You understand? So for that purpose, decarceration was a good response, but notably, we couldn't release and reduce the number as compared to as much as we wanted to. Because currently, we still have about 14,000 people in custody in Ghana. So it's still a challenge, but we are trying our best. Can I have the next slide? Okay. So among the issues, we realized due to the overpopulation, we couldn't put in some of the preventive measures with regards to COVID and how to contain the spread of it. Because inmates were sleeping in a cell that's supposed to take like 50 people, like a dormitory containing 50 people, holding about 120 people. So it was a very big challenge for us. So we developed the mark system. Instead of giving marks to every inmate, we give out marks to every inmate so that they can be changed. The material ones, not the N95 and those surgical marks, the material ones. And we realized officers were the agents of, if they will be a care, officers will be the agent because they were moving in and out of the unit. So officers were also incorporated into it and giving marks. Also, we spoke to some of the leaders in the prisons unit in as much as educating prisoners about it, because most of them, Ghana generally, due to the illiteracy level, some of them superstitiously didn't believe COVID was real. And as much as with every education, they never believed COVID was real. So we had to develop the education system to educate them about it. And some of them saw it like, no, because in Ghana, initially, from the general government perspective of COVID, was more of the elite people who were being reported of getting the disease as against the low-class economic people. So the prisoners were in doubtful. We had to increase our education purpose. But in as much as you educate a person, he was already preoccupied with suspicion that COVID wasn't real. So it became a very huge challenge for us. We also wanted to screen all officers and inmates, but I realized due to economic challenges, we were not able to. And the Ghana Health Service didn't incorporate prisons health initially into their scope of care. So one or the other, we have to speak to some benevolent individuals to come to our aid. And now was the time to do the test. And you know, the prison settings in Ghana is not well equipped with adequate modern health units. So it became a challenge. We couldn't do that until one inmate fell sick. Initially, we thought it was tuberculosis. So we made a referral to a higher facility. He got there, he was screened, and later it turned out to be a positive case. And later on, one officer also tested positive. So we realized there was a link between the inmates and the officer. So both of them went into isolation, but gladly they both recovered. And the officer is back to his facility working, and the inmate is still in prison custody. The inmate wasn't released because looking at the sentence, it was a murder case. In Ghana, murder case, you hold them in high esteem. You can't just let the person go like that. So those are some of the issues that came up. But one or the other, we had some opportunities too, because it made the government to recognize the prison health as a public health. Because initially, the prison health was not incorporated in the government system. So now, my unit has been added to the government's health insurance scheme, whereby prisoners are being taken care of. And also, officers are given some incentives. And because of the reduction in the number of inmates, the government expenditure, as in the welfare, regards to feeding and other stuff, have reduced. Because in Ghana, in as much as the government is trying, he only spends less than $1 Australian dollar on an inmate per day, which is very abysmal. And we're trying to make things work, but due to the economic fortune, the government's, because looking at the varieties of education problem and other healthcare system, the government would rather spend in education rather than bringing it to the prison custody. So I think for now, those are what we are up to. I think I'll leave it here for somebody else to continue. In case of any question.
Thanks very much, Rashad. If, again, I'm just skipping through these slides quickly so that the audience can see them as we go through. But
No problem.
Again, Claire, any burning questions before we move on to our fourth and final presenter?
No, I think they can all wait for the end.
Excellent. Thank you very much, Rashad. Again, you've raised some really important points that I'm keen for us to come back to in the discussion section. So thank you very much for that. So on to our fourth, last but certainly not least speaker, Dr. Paul Simpson from University of New South Wales. Paul, again, over to you, and please just direct me to move to the next slide as you need it.
Okay, thanks, Stuart. I'd like to also acknowledge the traditional owners of where I'm presenting on today in Marrickville, the Gadigal people of the Eora Nation, and pay my respects to the elders past, present and emerging. I've just structured this presentation based on the 4 questions that were given to us, looking at how important decarceration has been as a response to COVID, a key issue around this, what's missing, and priorities in the coming years. Next slide. So I guess just to be a strict empiricist, I guess objectively we don't know how important decarceration has been as a response to COVID in terms of it being effective in preventing and containing prison or cross-community outbreaks. But Lisa's just presented some empirical data, so that's a great start. I was about to say we simply don't have reliable data right now in terms of to see how overall decarceration is as a strategy. However, there's 3 things that tell us that decarceration is likely to be an important response. Or we already know that decarceration can work when it comes to infectious diseases, in other words. First, we have historical examples of obviously prisons as incubators of infectious diseases, where the release of prisoners to stem overcrowding carried both benefits and costs, however. The well-known case in the 90s, the overcrowding in Russian prisons, saw tuberculosis outbreaks sweep through the prison population. And amnesties to relieve overcrowding saw around 300 to 400,000 prisoners released. I mean, this undoubtedly had an immediate effect to reduce crowding and TB transmission in prisons. So that worked, but it also contributed to an upturn in TB incidence in the community, as many were released, who were released had active TB, but I'll just return to that part. So this suggests the timing of decarceration is important, that addressing prison crowding should occur before an outbreak begins, but I'll return again to that. Second, before COVID came along, colleagues and I conducted a systematic review to assess the evidence on the association between prison cell spatial density, which is a measure of crowding, and infectious disease transmission amongst prisoners. We screened around 5,000 articles, and 7 made the eligibility, coming from studies coming from the US, Nigeria, Chile, and Pakistan. And even though some of the quality of some of the studies were poor to fair, we found mostly consistent evidence that prison cell spatial density is linked to infectious disease transmission in prisons. Probably no big surprise, but here we have a body of evidence telling us that before COVID came along. So this review substantiates the claim that physical distancing in prison accommodation cell counts and works. And third, I guess the third reason, coming from a clinical point of view, what I call the asymptomatic issue. And again, Lisa referred to this issue as well. And looking from the Australian context as well, because that's where I've been looking at more closely, the measures introduced by many governments appears to rely on the assumption that COVID is containable just through the identification of staff and prisoners with clinical symptoms and mostly flu-like symptoms. And it overlooks completely the issue of asymptomatic cases, which are likely, studies showing this could range from 20 to 60%. But we've also had reports of 96% of prisoners in 4 US state prisons who tested COVID-19 positive were asymptomatic. So that's a huge proportion of asymptomatic cases. So if transmission from asymptomatic cases represents a substantial proportion of transmissions in prisons, then this has significant implications, obviously, for people incarcerated and those responsible for their care. And it suggests that most existing prevention measures reliant on syndromic surveillance will not stop COVID transmission in prisons, full stop. So given this, serious consideration needs to be given to additional measures, and of course, decarceration is an obvious one as the evidence backs up. Next slide. Next slide, yep. So one key issue I want to look at is, and Lorana touched on this as well, is the reactive approach. I think one of the big issues, again, from the Australian context, is the reactive approach to decarceration that's probably occurring. So ideally, decarceration should be initiated before an index case enters the prison, as obviously preventing an outbreak is likely to carry fewer challenges and reduced health, mortality and economic costs than controlling a substantial outbreak in prison, as countries like the US and Brazil illustrate, as well as managing potential cross-transmission in the wider community, as the TB prison outbreaks in Russia I mentioned earlier tell us. So initiating decarceration before an index case is detected is obviously the preventative approach, but most prison services are likely to take the reactive approach. And as an example, I would argue is New South Wales currently. Next slide. So as Lorana mentioned, New South Wales and Victoria, similar, has reported an 11% decrease in the prison population between March and the end of May this year, as the top two figures illustrate. But this drop came from higher number of unfinalised court proceedings and a high number of people getting bail. While this may be seen as decarceration, for many it is simply delayed incarceration. For substantive reductions in prison spatial density, substantial reductions in prison spatial density, decarceration will also have to come from releasing sentence prisons, the other end of the criminal justice system. And as Lorana mentioned again, although new laws were introduced in New South Wales giving the Corrective Services Commissioner the power to grant conditional parole to low-risk categories of prisoners during the pandemic. These laws have not been used yet, as the bottom figure shows. So prison authorities in this example, and I can imagine in many other countries, seem to be adopting a wait-and-see approach, suggestive or reactive, not preventative approach. I would say that today, COVID cases detected in Australian prisons and prison hospitals has been low, single digits, and gives it actually currently well placed to undertake a preventative approach to decarceration to maintain this track record. Next slide. I guess the second issue I probably wanted to talk about is, I guess I've labelled it mitigating the collateral effects of existing prison COVID measures. So, as many know, existing measures can range from stopping visits by family, stricter lockdown measures, which include more time confined in cells, cell isolation or quarantine, to the reduction or removal of meaningful activities like exercise, education, training, work, and informal socialisings. And it's not too much of an argument to build to suggest that these measures increase the likelihood of poor mental health, as well as prisoner resistance and harm, including riots, as been reported here in Australia and internationally. And as well, these measures also have human rights implications. The Mandela Rules 48 and 58 state that solitary confinement excess of 15 consecutive days constitutes cruel, inhumane and degrading treatment or punishment. And Rule 14 also states that the means of family contact may only be restricted for a limited time period and must include physical visits. At the moment, currently a lot of the visits rely on audiovisual links. So there's that sort of tension and issue of balancing the public health measures with the actual well-being and human rights of prisoners that's been flagged before. So decarceration is probably not the end solution that deals with that tension, but it may mitigate some of these collateral effects, but may not be available for everyone. So who is left behind in the decarceration strategies? Next slide. So what is missing from the response in relation to decarceration? Again, looking at Australia, while there has been legislative and judicial moves towards decarceration, I think, again, as Lorana mentioned, I think there's been a lack of investment and discourse on community reintegration preparedness for those who are or may be released. Well-managed decarceration program requires a continuity of care approach, as referred to earlier, which includes integrated health, social and economic support for those released. And of course, without such investment, we know the risks, that a lot of us know the health risk, poor health outcomes, including COVID infection in the communities with high prevalence, mortality, homelessness, and recidivism. And this situation is probably more acute when returning to a community which has COVID-19 restrictions in place, such as Victoria. These type of programs will require effective collaboration, obviously, between government departments and, of course, prisoner support organisations and NGOs. And something Dr. Eleanor Leclerc spoke at last week's webinar, and which has come out in some of the research we undertook with senior public office bearers on decarceration models, is that this complexity, what's involved in reintegration, and the political risk of decarceration and the resources needed for reintegration to be done right, may contribute to a lack of governance and leadership on activating decarceration strategies. It's just too risky, too complex, too resource heavy. So what I'm arguing, I guess, is this may contribute to the status quo of incarceration. Incarceration becomes a default option, and we get that wait and see approach, that wait and see, reactive, not a preventative approach. And next slide, Stuart. So in terms of priorities, I guess look, there's a lot of things needed in the context of COVID-19 in prisons, but just focusing on decarceration context, I think an immediate decarceration strategy should be targeting prisons with crowding, high spatial density. Spatial density levels, there's different ways to measure crowding in prisons, and a lot of them are I guess, subject to manipulation. I think prison cell spatial density is quite an objective measure. And I guess I would like to see some sort of spatial density threshold created, which would activate decarceration strategies in prisons, and also ensuring there is transparency of prison spatial density reporting. Also, I think we should be obviously listening to prisoner support and peer-based organisation to know what's needed in the community right now, and get that reintegration preparedness happening for decarceration strategies. And I guess a practical issue, particularly in releasing to community in places where COVID restrictions are happening, some investment in telehealth and telesocial services. A bit more long term, it's been mentioned again, service-wise, in terms of those models of continuity of care, there's probably more investment and design of sort of optimal models that are needed, which are integrative, holistic, and includes housing. And I guess the bigger challenges over the long term, which may be longer than the 3 years, is changing public attitudes to prisoners. I think that would help encourage, I guess, authorities and the public supporting decarceration moves. And so, recognising the merits of a social determinants approach to health and crime and not a punitive one. And this, looking for that to feed into recognising that decarceration as an opportunity, realising that community-based alternatives to prison are both humane and in the broader public health interest. Okay, thank you.
Thanks very much, Paul. And thanks for valiantly proceeding there with the airplane flying low overhead. I could hear it.
Yes, sorry, it's Marrickville.
Look, thank you, and thank you to all of our presenters. There are lots of issues there that we could unpack. Just before I hand over to Claire, I think one thing that came through in everybody's presentation was the recognition that some of the issues that we're talking about here are not new. And in a sense, COVID has been kind of a pressure test and a vehicle to highlight the importance of decarceration and different approaches to incarceration. And I think that's something that came through in everyone's presentation from at least Australia, Ghana, and the US. So it was interesting to see that. I'll hand over now to Claire to take us through some of the questions in the Q&A.
Thanks so much for all of your presentations. It was very interesting. So I'm just going to pull out some questions and sort of combine them together. And if you have any questions, please keep sending them through, and I'll try and see them as they come in. So I think the first one is sort of just like a very broad question. We've talked about the need for decarceration, and in the short term about the need to reduce the number, like release people who are on sentences, and also reduce the number of people going into prison. Are there any countries or systems that you know of that are actually doing this well, and that we could learn from in this sort of response? So I'll just leave that open if anyone has a comment on that. Lorana, maybe did you have anything you could add on that?
I'm not sure. I mean, I've certainly heard reports, Iran released tens of thousands of people from prison, Ethiopia as well, early on. The UK made some bold announcements, but I think only released maybe 5,000 before they did an about turn on that. Yeah, and I don't know what's happening actually in the Scandinavian and Benelux countries, and whether they've been particularly proactive, but of course they've had a lower base to start with. I can't comment on Ghana, but certainly than the US or Australia. So I think we probably have here a lot more, you know, for want of a better term, low-hanging fruit, actually, of people we could and should be releasing.
Yeah, I would just add to that. Look, I tried to dig around and look at other countries' decarceration to get sort of, try to find out what's happening, some reliable figures, and it's actually quite difficult. And the situation is moving rapidly. I mean, I guess from my perspective, I would think decarceration strategies should be initiated as soon as there are indications of outbreaks in the community. I'm unaware of any nation state that's undertaken that approach. I may be wrong, because there are some, as I said, it's really hard to get official data out and reporting. But obviously there has been some countries like the Philippines, Iran, that have released significant amounts of prisoners, but we don't know and I think the Philippines initiated 22,000 prisoners released when they had maybe a couple of hundred or a few hundred active cases in prisons. And I think they've managed currently now, it's managed at around 100, but there's always, risk of outbreaks varying. So COVID hasn't been eliminated from that strategy, but still that was a promising sort of sign.
I think I'd add to that and just say that I think it's also important to contextualize it as a non-static process. It's not a moment in time of decarceration. In order to actually take effect, it has to be an ongoing process of intentional non-incarceration, early release, elimination of money bail, all of these things. Because, for example, in the US, between March and May, jails released 30% of detained people. And then since that time, it's gone back up almost to the place where they started. And so as some of those communities opened up again and suddenly courts back in session, and these are things that you do them it's not a one-shot deal and then you've accomplished the goal. In order to have a lasting impact, these have to be intentional, systematic, ongoing efforts, or else you just quickly bounce back up, and from a public health standpoint, like, you actually maybe haven't achieved much then.
I was curious Rashad, whether your experience is that you said there was quite a substantial drop in the prison population. One prison you're saying went from 2,000, it was reduced by about 1,500. Do you think that's delaying incarceration, or do you think that there have been some changes that are likely to be sustained in Ghana on the back of this?
Well, in as much as we're trying to decarcerate, the same way we're incarceration, because looking at the crime rates, I remember by the time the first week we made out of 1,000 within a weekly, we had just my facility alone, we had about 200 new cases. So it was a big challenge. As much as you are trying to take people out due to Corona, the more people are coming in due to economic situations and the crime rates here. So we're trying our best. For now, the most purposeful thing is to try and do the basic principles of Corona, maintain the hygiene and cleaning surfaces, and educating people about it. That's what we are doing now.
I think one of the things that came out to me is there's sort of this difference between the political will and then what's happening on the ground. So there's no political will to sort of break away from this rhetoric of being tough on crime, but actually in reality, judges or police officers are offering some discretion in order to sort of reduce what is a risk. Can you comment on what are the pros and the cons of this sort of silent movement towards decarceration that doesn't get any public or policy perspective, but is happening in reality to some extent, at least? Maybe Lisa, because the US, I think, has this problem where you've got these numbers. So maybe if you could comment.
Well, I think it's a double-edged sword. It's good, of course, and it's dangerous, because going back to what I said last, is that when you don't make things into policies or intentional, or you publish what you're doing and have to be held accountable, then there's a very quick slippery slope backwards once somebody changes their mind, or a judge gets moved to a different circuit and somebody new comes in, or it's too reliant then on individual factors. And I think when we're talking about infectious disease control and public health, it can't be based on individual factors. This needs to be really across the board, again, systematic, public knowledge, published, put it out there so that it can then be checked, monitored, measured, all of those things that we know matter, and hold people accountable. So that's the part I worry about, and that we've seen happen here in the US.
I think also one of the risks, if it happens sort of by stealth, is that then there by necessity isn't going to be the degree of planning that's required around housing, for example. So if this were something that governments were willing to say, okay, we're going to do this, and certainly in Australia, the public opinion aspect, where public opinion on a lot of these issues lies, is far less punitive than people imagine it to be. So there's this tradition of politicians saying, well, this is what the public wants, but doing so off the back of either, top of head media polls, or often, I think, no research at all, and what they think the public wants. So I think, this would be an opportune time to gauge what the public actually wants. But certainly if we go off historical data, when presented with the options of, do you think that people with mental illness should be treated in the community? Do you think young people should be treated in the community, or kept in the community? Support for that in Australia tends to hover around the 85+%. So non-violent offenders, people with substance abuse issues. So, there's much less popular support for the punitive rhetoric than is generally imagined. And if the politicians could take the research seriously and then say, okay, well, we're going to invest in the things that are required in the community, and we're going to do this in a strategic and managed way, as opposed to this ad hoc, case by case, this magistrate is sympathetic, or this police officer exercises their discretion in a way that they might otherwise not, we'd have far better outcomes. But of course, the political will tends to be lacking. And just on the point, Paul pointed out that a lot of that drop in New South Wales is at the front end, the bail and remand side, as opposed to sentence. That's absolutely correct. I don't necessarily agree that that's just delaying the inevitable. If a lot of the time what happens in the courts is someone's been remanded for months, or in some instances years, and you have a judicial officer saying, well, I wouldn't have given you this long, but I don't have any option now. So it could well be that when the matter comes on, assuming that they get found guilty, which they may not, that you'll have a judicial officer saying, well, you've been successful in the community for all the months it took for this to go on. I don't see any reason to impose a prison sentence now. And if we look at the data in Australia of people entering the prison system, 74%, 78%, something like that, are unsentenced. So if we could tackle that front end, it would do an awful lot to reduce numbers.
Great, thanks for that. I think that sort of leads quite well into sort of this other issue that came up that Paul brought up about what happens in prisons too with people who are left in prisons, because unfortunately, we're still in a situation where there's going to be people in prison. So there are all these methods now that are in place. So, you have face masks and social distancing, and as we talked about, a lot of these rights that have and collateral effects. How do we balance these people who are left in prison when there are, there's this ongoing public health risk, and now we're talking about moving into, months and years of this rather than this emergency phase? How do we balance these two requirements, even in like specific things like wearing face masks when it's not possible to social distance, and that's 24 hours a day? Maybe if we can throw this to Rashad to start with, how are you finding balancing this public health risk with all these other factors in prisons?
My facilities like this, we are never supplied with PPEs from the government. We just have to make a plea to some benevolent people. So we had one NGO from UK sending us some PPEs, which came in handy. But with the government supply equipment, we never had some because we were not budgeted into it. As I said earlier, the prisons were not incorporated into the general health system. So with the inmates, we were only able to provide material masks. We were able to provide a surgical and some of the N95. So we tried making it available. We made it 2 for each inmate with a population of about 2,000. So we supply about 4,000 masks. So in as much as the person will be rotating them, making them neat and cleaning and reusable masks, that's what we're able to do.
Thanks, Rashad. And maybe some of Australian people as well, a big response to ours has been holding people in quarantine when they enter prisons, even though there aren't that many cases in Australian prisons right now. What do you think about this sort of response? Is it out of line with we really want to stop COVID getting into prisons? As you talked about, it's really important to be proactive, but is that level of control sort of out of line with the risk at the moment? I guess maybe that's probably a question for Paul.
Yeah, I guess, yeah, it does raises, an ethical issue that sort of dogs public health discourse and has over the years. But I guess if you look at the alternative in terms of the risk involved in outbreaks, I would suggest quarantine and testing is a reasonable measure to prevent COVID from entering prisons. I would also add I guess, and US data is bringing this out. There's a high risk that it is staff who are bringing it into prisons, and currently, while prison entrants or people entering custody are getting tested in New South Wales and Victoria, I'm not sure about the other jurisdictions, staff are not. And I guess this is a resource and logistical issue as well, that I think I saw some data coming out of the US Center of Disease Control suggesting that out of all the prisons that they got their hands on data, over 50% of prisons that had at least one confirmed COVID case came from staff alone, not prisoners. And we've had cases in Australia, in Queensland, Long Bay Jail, prison hospital at Long Bay, and I think in Victoria as well. So I think staff is a big issue. Going back to the issue about balancing human rights and the collateral effects, I think an important aspect to focus on, I think, is maybe, and again, it's a resourcing issue, is the mental health care that happens in prison. We know from reliable data that prisoner populations have a high prevalence of mental health and well-being concerns and issues, and there is some question around the extent of mental health care that's available in prison, which should be equivalent to what's available or more in the community. So I think, we've seen a lot of money thrown around by government since COVID has happened. We're all willing to go in debt. I just think healthcare and mental health care can, some money can get chucked at that perhaps to sort of mitigate some of these collateral effects, as we're calling them.
Definitely. I think that's a really good point. And just on a related note, Lisa, I was interested in your perspective. I know in the US, we've got sort of this mental health and substance use crisis of the overdose opioid crisis happening at the same time. And data coming out of Canada is suggesting that this is becoming a lot worse at the time of COVID. So how do we manage this in the community when we have these different conflicting health priorities that are affecting people in prison and then when they move into the community?
I think it's a great question and an important one, and data in the US is showing the same. And in the addiction world, we have anticipated that as well, right? You create social isolation, you close down peer support groups, you close down facilities, and you add stress, economic hardship, and all of this, and it's just the recipe for bad things to happen. And I think that, I don't know though that they're disparate aims. Like I really do think though that what it takes is the same stuff, which is flexibility, right? We're just like so black and white about it, where the groups are either opened or they're closed, right? Where we know well that masked and outside peer support groups are probably quite safe to go on. We know that it requires, in the US, we have gained flexibility that we never had around community prescribing of medications for opioid use disorder. So I'm able now to start and continue someone on buprenorphine in my clinic without seeing them in person. Now that's not to be done haphazardly, but of course that's necessary. That was necessary before COVID, and it's necessary now. And I think that type of flexibility is actually what it takes. You know, it's really it's what we've always needed to do in healthcare, and we don't do very well in the US at all, which is just meeting people where they are with what they need, right? Instead of that they have to come during your hours of operation and, you know, be on time and, you know, all these things, these false kind of barriers that we erect to treatment for addiction. Telemedicine, right? It opens up a whole new universe. Take home bottles for methadone, you know, it actually goes well, right? Like other countries have been doing this for ages, you know, in Europe, methadone dispensed at pharmacies, in Canada, right? So that sort of flexibility is totally in line with actually the type of flexibility people need when they're coming home from prison and jail as well, right? They need places that are open, that are able to see them promptly, that fit them in with some priority of recognizing their health risks. And so that doesn't fix the whole problem, but when you get to evidence-based treatments for addiction, part of that is medications for a number of substances, and access to those medications has to be prioritized by the system and then flexible. And I think that offers, kind of aligns the needs of people leaving correctional facilities in general and people with addictions, and then the co-occurring scenarios. Yeah, the social isolation part is the hardest part, and that can also be the hardest part for people coming home who don't have family around, or you know, don't have family able to take them in, and that's a much bigger problem without an easy solution. But I think a community-based solution that's out there.
I think as you said, that flexibility really sums up what's necessary in the whole of this system, and something that the criminal justice system hasn't done very well. Thank you all for that. I'm going to hand back to Stuart now just to wrap everything up.
Thanks, Claire. Look, I've tried to take notes and capture some of the main themes discussed, and we've covered a lot of ground tonight. Very, very quickly, a few of the things that came up, I think repeatedly, was the notion of we should be proactive rather than reactive in initiating a decarceration effort. I think both Lorana and Paul made that point. Lisa, I think, made the point that community health and welfare services need to be appropriately resourced if we're going to decarcerate. We need to have community resources there to meet the demand that will create. Rashad made the comment that COVID, in a sense, was a blessing in disguise. It's been, by the sounds of it, at least in some settings, a vehicle for decarceration that's been sorely needed. And then a few points that Paul made, that nevertheless incarceration, at least in the Australian context, seems to still be the default option, and we're waiting and seeing rather than being proactive as we should be. We only have a few minutes left, but can I invite each of our speakers in 30 seconds or less to make any final remark, mostly singular rather than plural. I'd hate for us to be cut off before we're done. Just based on the conversation, any final things you'd like to comment to our audience tonight? I'll start again with you, Lorana.
I think the challenge for all of us who care about this issue is to engage with the public and get through to them the importance of decarceration for moral reasons, for practical reasons, for economic reasons, for health reasons, and to have those discussions. And certainly my experience is we're closer than we might think we are on this. And then, of course, the next step for them would be to engage with their friends, family, politicians, and the like, and start that discourse more broadly.
Thank you. Lisa.
That's a tough one, but I'd say something we haven't talked a ton about would be the real central role of people who are incarcerated, family members, and previously incarcerated people in leading these efforts to what we really need, which is more data, studying it, measuring it, monitoring it, and holding governmental systems accountable. And I think that when people who have lived experience or direct impact from incarceration in their families or with loved ones, the right questions get asked or get nuanced in a way that's most effective, most impactful. And I think that in the absence of that, our questions and our approaches will never be good enough. So I think really centering people who have lived experience in the work, both practical work and research, is critical.
Terrific point. Thank you. Rashad, any final comment?
All right. This one, I like to say, so far as now, COVID has become a major issue in Ghana now, because now there's been a discharge and recovery rates all being put together, and people are in doubt how the cases are being sprung up. So with the prison settings, I think we need more support from the government and other NGOs, and also establishment of more new deemed prison facilities with adequate health units and recruiting more health professionals. Because for instance, my facility, I'm the only mental health nurse there. And in the services of the whole Ghana, I think we are only 10. We are not even up to 15. We are only 10 nationwide. And mental health has become predominant in prison settings because of the incarceration and the setting in and bringing up depression and so stuff. So we will say, so far so good. You pray and you hope things will surely change.
Thank you, Rashad, and we hope so too. And finally, Paul, any final comment from you?
Saying they're all really good final comments, and I guess I'll get a bit starry-eyed. Maybe our Prime Minister used this term, this snapback narrative about we have to snap back to the norm before what happened in COVID. And I just hope we don't really engage in that in terms of an incarceration rate context. I think it would be good before we engage in that to have some sort of critical reflection of what's going on, and to sort of think new things, do things in new ways that are perhaps a bit more humane and in the broader public health interest. And I think maybe decarceration hopefully is one such opportunity there.
Right. Thank you, Paul. We are about to finish, so before we get cut off, I want to again thank our presenters very, very much for taking the time to share their thoughts and their expertise with us. So we're very grateful for your time. And anyone who's interested in the other webinars for the rest of this year, please just follow the unit on the Justice Health Unit on Twitter, Google us and find the webinars. We would love to see you at the future webinars for the rest of this year. Everyone be safe, be well, and look forward to seeing you at the next one.